Good afternoon, everyone. I think we'll get started. My name is Anna Greenberg, and I'm Vice President of Health System Performance at Health Quality Ontario. And as you know, today's session is about patient experience measurement and building a strategy for Ontario. Before we get started, I just want to thank the team that organized this session and organized who our speakers would be. I think you're in for a treat. So thank you to Gail Dobell, Jonathan Lamb, Bernadette Coe, Marg Millward, and Gayleen Prom. So our panel has no commercial interest to disclose, and this session has not received any commercial support. And you'll probably have noticed that in front of you on the seat are some clickers, and this is because we'd like to do some audience polling. And any of the materials from this session will be available online after the event. Okay, so we wanted to cover two big things in this session. The first is to learn about patient experience measurement underway in Ontario, and a little bit from BC as well, and also to give you an opportunity to provide input into a patient experience measurement strategy for Ontario, and you'll hear more about that. So it's my pleasure to introduce our panelists for today. The first speaker is going to be Paul Taylor, and Paul Taylor is a patient navigation advisor at Sunnybrook Health Sciences Centre. And he was previously health editor at the Globe and Mail, and he launched the Globe's first weekly health section. These are just the top line of people's bios. You'll see the full details in your package. Lena Cuthbertson, for over a decade, has led the BC strategy for the measurement and reporting of patient-centered care, and previously was a Picker Institute Fellow and sits on the Canadian Partnership Against Cancer's Person-Centered Perspective Measurement Steering Committee. And finally, Kim Baker is Chief Executive Officer at the Central Local Health Integration Network, or LIN. And a big focus of Kim's leadership in the LIN has been on quality, engagement, and improving the patient experience. So this session is about the need for a more coordinated approach to measuring the patient experience in Ontario. And Ontario has traditionally had sector-specific or sector-led patient experience measurement. And you'll probably know that some sectors are further ahead, have had a longer history, and may have had more or less success than others. But measurement in silos has led, in some cases, to duplications, and some cases to gaps altogether, and sometimes leaving out measurement in some of the most important moments in a patient's experience, sometimes in the transitions between sectors or between periods of their care. Before I hand over the podium to Paul, I just wanted to kick off the session with a video. This is a video about a man whose name was Dave, and he was a locomotive engineer for the Canadian Pacific Rail. He was married, was a father and a grandfather before he succumbed to lung cancer in 2010, having been diagnosed in 2008. And Dave's story is just one illustration of what the perspectives are of a patient about what matters most. This is from an unscripted video series of patients that was produced by the Canadian Partnership Against Cancer in partnership with Dr. Mike Evans and documentary filmmaker Wendy Rowland.
My name is Dave Spear, and I live in a little village on the north shore of Lake Superior called Rossport, Ontario. I worked here most of my life as a locomotive engineer with Canadian Pacific Rail. And about a year ago, I suddenly was brought on with some severe shortness of breath. I couldn't explain it, and we did a X-ray and discovered some masses in my chest, and it turned out that it was a lung cancer. They determined that we could handle 6 weeks of radiation treatment along with 6 treatments of chemo. So it's been all winter ordeal. As a matter of fact, I just simply had my last chemotherapy treatment this past Monday. The treatment for the cancer is, as it's sometimes referred to as a full-time job. I can say that it's a job and a half when you live where I do, because it's pretty difficult here in the north. I live some 200 kilometers from where the treatment is actually performed. It's quite a distance to travel. That's just one way, so you figure 400 kilometers both ways. And this is a beautiful time of the year right now to travel that road between here and Thunder Bay, alongside the Lake Superior. But we turn it around, and then we make it January that you have to travel this road, and there's the black ice, and there's all the pitfalls of winter. And although in the beginning I thought that this is a piece of cake, my first chemo treatments I was able to tolerate rather well, and the first radiation treatments I could tolerate rather well. But I was driving myself back and forth this 400 kilometers. And I could handle that, but the treatment proved to be accumulative, and then it got much more difficult as time went on. And it became apparent at one point that I could fall asleep while driving, and I had to really watch myself very closely, and then had to come up with other methods of being able to get to and from the hospital in Thunder Bay, because of the possibility of having an accident and not only injuring myself but maybe someone else. So it's it's all consuming. It takes up your whole life and then some. You have to be very thankful to have some good people around you. It is a huge shock in the beginning when you first discover this kind of thing. You feel like a life sentence. You feel like this. I'm getting closer to my next journey, and what are we going to do? How do we solve? What do we got? Oh man, we got tons of things that we have to deal with. How long can we live in our home? Do we need to sell it now? Do we need to move to be closer to the cancer centers? I mean, there's just unbelievable amounts of questions, and having a partner who can sit down with you and pragmatically go over all these subject matters. And when you need help, bring in help. If you need an expert in financial assistance, bring them in. Call somebody up. Be it, have your healthcare team fully informed, have everybody fully informed. There's no reason for secrecy. It's foolish to be secret about these kinds of things. And I'm not trying to say that you need to tell the world, but you need to tell those who are important to you and who can help you. I know full well that what my capabilities are, and I don't want to go beyond that. I will seek out the assistance that I need, and in some cases I can be downright demanding. I will really go after what I think is necessary for my well-being as well as those around me. Being one's own advocate is probably the most important, for me at any rate, the most important issue of the entire procedure. I have learned that this is my body and it's my responsibilities. So I believe strongly in advocacy. I believe in strongly taking charge of your own health care. And that means questioning all of the medical people and clearly understanding what it is they're talking about, and trying to learn as much as you can so that you can keep the process going in a positive fashion, and full well realizing that what may look like something that would make life easier isn't necessarily the right way to go. You have to acquiesce to the experts, and there's good reasons why everybody says what they say, and you've got to listen. In my case, the radiation burns that came out on my back were fairly severe, and they were quite painful, and they wouldn't allow me to sleep at night. And although we put cream on them and things like that, it wasn't helpful. But I was visiting with the woundostomy people in another hospital, And I asked them to take a look at my back, and within minutes they had the pain gone. So you soon learn that there are people who have specialty skills that can help you, and you need to look out and seek out where those specialty skills lie. And I honestly believe that from the radiation oncologist, they were very pleased that I looked beyond them for help. It was, they too are searching for help to be able to alleviate people's pain. When I think about surprises, probably everything is a surprise because you're heading into an area of such little knowledge. At least for me, it's not an area that I had researched or looked into beforehand, and I know that I'm kind of flying by the seat of my pants and trying to learn as I go along, and it's so complicated that the learning curve is really huge. But I know, to be quite honest with you, I had 2 bad days when I first discovered I had cancer. 2 sleepless nights when I laid there and wondered about things like death. And at the end of which I said, this is a foolish waste of time. And I put it behind me, and I haven't looked back since. I have no intentions of wasting any more time on negativities and all the so-called sorrowful things. I have nothing to be sorrowful about. I'm still alive, and I'm still full of piss and vinegar, and I'm just going to give her. There's no question that developing cancer will change a person. There's absolutely no question about it at all. And I think that's part and parcel to probably the area that cancer and death are kind of go together, or have for so many years. I know that's changing, and I know that cancer is being beaten more and more all the time. But I think at the same token, one has to be a little bit pragmatic with respect to the whole issue, and knowing that there's some winners and some losers, but I think you can be a winner and a loser, I mean, regardless, and at the same time. But oh yes, does it ever change your life? As I said, I just finished my last chemotherapy last Monday, just a couple of days ago. And who knows, next year I might be going through exactly the same thing all over again. And at this stage of the game, I'm quite prepared to do that. How many times I'll be prepared to do that, I don't know. Whether or not it'll wear me out in the end, but or whether or not we can eradicate it and become a cancer survivor. I am certainly looking forward to being a cancer survivor at this stage of my game.
Good afternoon. Thank you for being here today. It's a hard act to follow, considering I'm not a patient, but I talk to a lot of patients. I think it's worthwhile for me to describe what I do at Sunnybrook. It's a fairly unique job. I'm not aware of anyone else doing anything the same at another Ontario hospital. Essentially, I answer questions emailed to me by patients or their family members. The questions are generally about how to navigate the healthcare system. I try to answer all of them, either by email or by phone. In some cases, I will post my responses in an online blog if I feel that other people might be able to learn from the experiences. Before I did this job, it was performed by Lisa Priest, who is also a former Globe and Mail journalist. Originally, the blog was just posted on Sunnybrook's website. Then Healthy Debate, which is at St. Mike's Hospital, asked to carry it too. Huffington Post decided to pick it up, and most recently it's now running in the Globe and Mail. So I'm getting questions from across Canada. The questions give a snapshot of the patient experience in Canada's healthcare system. They also provide insights into the type of information that patients are looking for, and as it relates to our talk here today, what type of information on the healthcare system should the healthcare system be collecting to meet the needs of patients. In many respects, my role at Sunnybrook is similar to my former job as a health editor and medical writer at the Globe and Mail. If people have a problem, they will often phone up a newspaper, hoping that a reporter will write a story about them and draw attention to their plight. I'm getting questions from people who are essentially lost in the system. They're the unrecorded voices, And at this point, I'd like to just turn briefly to the patients whose voices are and their experiences are recorded. There are two general types of information. One type comes from websites where patients rate their doctors or their hospitals where they've been treated online. The patients remain anonymous. They voluntarily log onto these websites, such as ratemd.com, to express their views and about their doctors. The other type of information is collected through the healthcare system. This administrative data may be derived from a review of patient medical charts, or it could come from an analysis of provincial records of doctor billings. The Canadian Institute of Health Information, for instance, uses billing information to create the Your Health System website, which provides comparisons of indicators such as hospital deaths and readmission rates. Now, the first thing that you need to know about the anonymous comments on the RateMyMD type of sites is that they don't necessarily represent, they're not a representative sample of patients. I just want to ask a question here. How many people in this audience have ever kind of gone on these websites and voiced a point of view about their doctor? Has anyone in this room done that? So we have one person to a few. It's a handful. I think as a general rule, it tends to be a very specific population of people who post online. People have to feel very strongly to make the effort to adding their opinion to a website. They tend to be patients who are either very happy with their doctor or very dissatisfied with their physician. So in a way, the reviews are kind of polarized. Furthermore, some points of view will be absent because not all patients are computer savvy. A doctor could do a great job looking after seniors, but very few of these patients might, make their views known online. Now, despite these limitations, the websites are a reflection of the patient experience, and they give us insights into what patients feel is good quality care. By contrast, the rating systems that are based on healthcare administrative data have the appearance of being more scientific and therefore may be more reliable. But the data can be misleading too, identifying minor differences that are not necessarily meaningful. Ratings based on numbers alone can't capture all the intangible experiences that may be important to patients. For instance, sometimes it's the environment that a patient is being treated in that's important. One hospital department might have received a large grant or donation for a brand new wing or major renovation, and the upgrade facilities can make patients feel better about their care. But also, this data doesn't really capture what the patients feel about what their experience has been. That said, I think it's a good thing to collect this administrative data and to make it publicly available, such as data on hospital infection rates or readmissions. No hospital wants to be at the bottom of one of these lists, so the information helps to motivate institutions to make changes, make improvements, and that can be worthwhile for patients. That can be the patient's improvement. And I'm not sure that many patients are using this administrative data as a way of choosing their own care. In most cases, care is based upon a referral pattern of their family physician. There's not a lot of choice in this matter for the patient. And a lot of patients, the main question is not where should I have an operation performed, but instead the question is when will I have my operation? If it's not an urgent matter, patients often wait a very long time for a test or a procedure. So at this point, I'd like to show you some of the examples of the questions that I've been getting, because they're fairly illustrative of some of the issues. This is from a man. It's also and many of the questions also come from the family members, not necessarily from the patient. So I got this email from a man who was expressing concern about his aging father, had to wait a year for an operation. He needed a hip repair operation. Now, it's worth noting that there is information available about hip replacements, comparing wait times at different hospitals in Ontario, but the data does not include hip repairs. So what's available online was no help to this family. Now, it's possible the patient's experience does get captured someplace in a wait time indicator, but it says nothing about this patient's experience about managing their own care, nor does it reflect the poor coordination of the care. So that information just isn't captured. Here is another question. Again, it's a typical question, and it relates to timeliness of access to care. In this case, the woman is asking about the wait time for test results regarding her mother, who has cancer. A lot of the patients don't know what to expect in terms of the test results and treatments. So this is clearly, and this is particularly evident in the cancer patients. So they're very anxious, especially when they wait a long time for test results. They don't know how long they should be waiting. And when it doesn't seem to be happening fast enough, they think something is wrong, or they don't know whom they can contact for information. And in this case, the patient up here on the screen, there was obviously some kind of failure of communication between the care provider and the patients, or the patient's family. I also get a lot of questions from people who are seeking a second opinion. They seem extremely hesitant to ask their doctors for a referral to another physician who could provide a second opinion. I think they may be worried that their doctor will be offended. I talked to several cancer surgeons at Sunnybrook, and they said they seldom get asked by their patients for a referral for a second opinion. Now, of course, I'm not a clinician, so when I get these questions, they're hard because I can't give them a second opinion. But what I do is I tell them it's okay to ask for a second opinion. I tell them about how going about that and try to give them the confidence to do what they should be doing. But the fact that patients turn to me, a navigator who's not even at their own hospital, is further evidence that some patients are not comfortable letting their doctors or their hospitals know that they're looking for a second opinion. So when it comes to planning new ways of measuring types of patient experience, we have to ask, will patients be comfortable sharing their feelings or of dissatisfaction with a facility that might be continued involved in their care? In other words, who should be collecting this information from the patient if we want it to be reliable? Here's another question. And I also get a significant number of questions. And this is fascinating. I get about 2 or 3 questions a week from people who are moving across Canada, and they want to make sure that there's going to be continuity in their care. From their home problem. Sometimes the questions come from individuals who are moving, and other times it comes from families who want to move a family member closer to them so they can look after them. So I think it's fairly fair that these questions highlight some of the themes that patients experience that should be measured. For example, are patients being properly informed about their health by their healthcare providers? If not, why are there gaps in communication? And if so we, in general, don't collect the kind of information that a lot of people use. Now, there are some examples. There is some examples we're collecting. But what's interesting is that in England, the National Healthcare Service has been gathering data on the effectiveness of care delivered to patients as perceived by the patients themselves. It's called Patient-Reported Outcome Measures, or PROMs. To get input, hospitals in England have been inviting patients to complete questionnaires before and after certain types of surgeries, including like hernia operations, hip and knee replacements, varicose vein operations. And in many ways, the UK strategies are laudable. There's not a lot of this kind of data being collected in Canada. There are some examples, and I think your next speaker is going to be talking about that, about what they do. I think that this kind of information might be more useful to patients when they're making decisions about their own care. As well, it could point to new ways of improving delivery of healthcare here. So I'm going to stop at this point, and I'm just going to show you one final question on the slide here. And this is basically another patient who I guess that's it. But basically, the questions I get really do show examples of people who are lost in the system, and we need to do a better job of collecting that kind of information. I'll leave it there.
Is this what I used to advance my slides? Okay. Hi, everyone. My name's Lena Cuthbertson, and I'm delighted to have 15 minutes to share with you our 13-year journey in the province of British Columbia around provincially coordinated measurement of patient experience. So fasten your seatbelts. Okay, so what I want to try to cover, what I've been asked to try to cover today, is to share our learnings in the province of British Columbia. So if the province of Ontario makes a commitment to moving forward with provincially coordinated measurement of patient experience, what could they learn from the province of British Columbia so you wouldn't have to go through, I'm not sure I would call what we've done mistakes, but how could you accelerate your process? So what have we learned about the science? And I just really want to emphasize the word science. I will come back to that again. But what have we learned about the science of patient-centered performance measurement? So a goal for us in the province of British Columbia was measurement of the quality of the healthcare system through the patient's eyes. So the commitment in the province of British Columbia was that the final arbiter of the quality of our healthcare system could only be the patients who were receiving care. And since then, we've expanded that to include family members. And then the other objective for the session today is really, what have we learned about best practices for supporting how to get the message out to frontline clinicians, to leaders, to people interested in quality improvement, to people who can make a difference in the experience of patients and will truly act on the results. So my personal goal has always been, and I believe I've been successful in having us embrace this through the whole province of British Columbia, is how do we translate data? How do we translate numbers into information? How do we take the voice of patients that we collect and generate numbers into what really resonates for people who are working with patients at the point of care, translate that into information, and then use the information to encourage action so that we can actually improve the experience of our patients in our province? I have to push really hard on this dot. Oh, and now I pushed too far, so now I have to go back. Okay, so our accomplishments over a period of a decade, we have centrally coordinated in our province, province-wide coordinated surveys. That means there is no cherry picking. If our leadership council, our deputy minister, and our health authority CEOs deem it a priority to survey patients, to get feedback, the voice of patients in a particular area, everyone participates, every service, every location. There is no cherry picking. Over a period of 13 years, we've gotten feedback from more than 1 million users of our healthcare system in 13 sectors and subsectors and across all age groups. The thing that I think was really a major turning point for us was when we realized that sharing quantitative information, the numbers, was not good enough. That to resonate, we had to tell people stories. The film that Anna showed, the stories that Paul gave us examples of, we really need to have the real lived experiences of people who have received healthcare services to illustrate the data, to translate it into information. So if you remember nothing else about what I've said today, the integration of qualitative and quantitative data is critical. The other thing is that it was not adequate for us to just disseminate the information, the numbers. We had to change the numbers into reports that could be easily read by people, and we had to help people to understand what the information meant, to make it effective, to support people who are trying their very best at the point of care to improve the experience for their patients and their families, but also to make it useful for accountability purposes. And the reality is accountability means judgment. And unless we have accountability frameworks in place, what is the impetus to act on the information? So we need both the people who are providing care in their hearts to recognize that the information that they have represents the voice of their own patients and that they want to act on it. It comes from themselves. And we have to have accountability frameworks that hold up, a stick or a carrot to say this can be better for our healthcare system. And lastly, it's the commitment to public reporting. Okay, so let's take a real quick look back. So we started our work in December 2001 when British Columbia streamlined our regional health boards, which were 52, comprised of over 250 hospitals, into 6 regional health authorities, with the goal that the patient voice would, as I indicated, be the final arbiter of the quality of our healthcare system. In June of 2002, so literally a year later, less than a year later, the British Columbia Patient Satisfaction Steering Committee was formed, representative of all the health authorities and the Ministry of Health. Now notice it was called Satisfaction, because I'll come back to that. Fast forward to February 2014, the British Columbia Ministry of Health publishes its health system strategy, and look what the number 1 key focus is. Again, notice it doesn't say patient satisfaction, it says patient-centered care. Oh, this thing is tough here. Okay, so I want to just start by, as we have gone through our journey, we have realized that a lot of words are used interchangeably and often incorrectly. So I guess the question I want you to think about is patient-centered measurement or patient-centered care the same thing as measuring patient satisfaction, patient experience, patient engagement, patient activation, patient-reported outcomes? Paul talked about PROMs. So are they all the same stripes on the zebra? This is the evolution of our approach. And again, this is another slide that if you don't remember anything else, I think this is an important one. When we started this work in 2002, we were focused on satisfaction. We wanted ratings. How did our patients rate their overall satisfaction with the healthcare services we provided in BC? And we were focused on sectors, emergency, acute care, et cetera. In 2003, so we were pretty quick to make this realization that, in fact, we wanted to measure patient satisfaction as an overall indicator, but we really needed to understand experience. So while satisfaction tells us on a scale of 1 to 10, 0 to 100, 1 to 5, excellent to terrible, excellent to poor, how satisfied people are, we have to make a judgment about whether that's good enough. If a patient tells you, could you injure yourself and no one would know, and the patients tell you that the answer to that is no, that's a report, and we are compelled to do something about that. So in 2003, we quickly embraced the notion that we had to measure both satisfaction and experience. In 2005, we're still measuring satisfaction and experience, but we realized that, whoa, we're doing all of this good work, reviewing the literature, selecting survey tools or developing survey tools that are valid, reliable, psychometrically sound, and we're measuring by sector. So we're using a consistent tool. But is the experience of a patient who's having a maternity experience in an acute care hospital the same as an 85-year-old on a medical unit, or someone with alternate level of care, or someone on a rehab unit? So we got the notion of measuring subsectors, using the same core tool, but either developing or adopting questions that would allow people receiving specialty care to be able to provide feedback on their experience that was more tailored and more targeted. And I could spend a whole hour telling you about the process, but suffice it to say, we asked patients what was important to them. We asked professionals what is actionable. Why focus on something that's not actionable, but we still wanted to make sure that it was important to patients. So fast forward to 2014, and we suddenly have the aha moment that actually what we really want to measure is patient-centered care, which includes understanding the global satisfaction of patients, their experience, but also their outcomes. And this was very heavily influenced by the work of Nick Black in the UK, so with NHS, where he has done research that shows that patients can and do discriminate between their experiences, their satisfaction, and their outcome. So how many people, if I just asked you by a show of hands, can think of a time where you had a great outcome, or a family member or a loved one had a fantastic outcome, but actually the experience wasn't very good. You went to the emergency department, you had a laceration, a broken limb, whatever, and it got dealt with, and you go on carrying on with your life. But actually the experience wasn't so great. That long wait times, you weren't given information about how long the wait would be or what to expect next, et cetera, right? A lot of people putting up their hands. But what about the opposite? A horrible outcome, but a fantastic experience. So the example that comes to mind is the physician who is telling a patient and their family member, like the video that we watched, that in fact, you have a terminal illness and the length of your life is, not going to be very much longer. But I'm here, I'm looking you in the eye, and I'm making a promise to you that I will be holding your hand the entire time. And you will have pain, but I have a toolkit to be able to address that pain. And what I need to know from you and your family is when you're having pain, how bad the pain is, etc. Horrible outcome, fantastic experience. So we've made a commitment in the province of British Columbia. We're going to measure sector and subsector. We're going to measure PREMs, patient-reported experience measures, also global ratings, and patient-reported outcomes. Now, we're lucky because in the province of British Columbia, we have Canada's research chair in PROMs, Dr. Rick Sawatsky at Trinity University, and he and I are now connected at the hip. But the other thing I want to mention is that we are also focusing our attention now, and is Jason Wolf in the room from the Barrel Institute? He was here today. So Jason taught me that you can have 30 different departments, 30 different professionals who are interfacing with a patient on a typical day, but they actually only have one experience. So we're focusing on that, and we're really looking at continuity across transitions. The other thing that we're focusing on is looking at blended surveys, so we're no longer going to be asking patients about their experience in a sector, but rather across sectors. So I won't go over this slide. This was just something Rick and I put together looking at patient-centered measurement, but I think I've addressed it. So lots of influences on our thinking. When we started, we looked at To Err is Human, Crossing the Quality Chasm reports, and you'll see that a lot of the same dimensions and domains are very common in a lot of the different theoretical frameworks. Our mandate was the coordinated, cost-efficient, scientifically rigorous approach to enhance both accountability and quality improvement. These are our guiding principles, evidence-based benchmarks. We never reinvent the wheel. We try to minimize data collection burden for the health authorities and clinicians, engage patients in helping us to ensure that what we're measuring is important and that we're measuring what we intend to measure. And the last one was the most brilliant, that it's a strategy and process that's complex and will evolve over time. So here are our goals: information about what's important to patients and their families, not what's important to patients, information that provides a snapshot or a baseline with a commitment to remeasuring, information that's representative of the population that's served, that's collected in a uniform manner, and that tells us what our patients really think so that people don't fear retaliation. And we've done studies of this in British Columbia where we've actually asked patients at the point of care, can you be 100% honest? And I won't get on my soapbox, but I'm happy to talk to anyone who's interested about real-time feedback versus retrospective data, because real-time feedback does put patients in a position where they have to provide or they're asked to provide feedback while they're still receiving care. So this is our mission statement: province-wide, standardized, scientifically rigorous, cost-effective, trending over time, and evidence-based. But the caveat is our information is not alone. It's complementary to other sources, and as you know, there are so many different ways to listen. This is just one more. So after a decade, we've heard from people, over 1 million people in all these different sectors and subsectors. This is just another way of looking at it. You're going to get all these slides. This is the role of our steering committee. I've already indicated that until 2010, we thought that once we had the reports and the data, we were good to go. What we learned was that we had to also get involved in sharing results. These are the challenges in measurement. I won't go over it, but remember I said our goal is to provide scientifically rigorous information. There are challenges in doing this work at a provincial level and having tools and methodologies, but there are ways to overcome them, so suffice that to say. So what have we learned? We've learned that our information's valid, but when I said to you that the information didn't get used, why was that? Well, this was a watershed moment for me. And again, I think this is a really critical quotation. Statistics are people with the tears wiped off. This is my mantra. This is my soapbox. And if you really want some interesting reading, read about Dr. Selikoff's work with asbestos. But at the end of the day, data is nothing unless it can be translated into information. What our stakeholders were asking for from us was faster, better, and easier to read reports. And so our solution was real examples from real people telling real stories, integrating comments from patients and the quantitative reports. And so here's an example. I'll just give you one example. Here's an example of an absolutely beautiful run chart, right, with confidence intervals. You know, isn't this gorgeous? But what people told us was they didn't know how to read it. They didn't have time to read it. A run chart like this for every single one of 64 questions was overwhelming. So what did we do? We hired an analyst who every single month interprets the data point for every single one of the reports and injects a patient comment. And Jason, who I know isn't in the room, came out to British Columbia, and together we met with emergency department front leaders, and we showed them how to lead with the patient comment and then to provide the quantitative. We did some really great work also looking at what were the drivers, and so there's a link there that you can look at where we found out that surgery was really important. There are 3 examples here of how we've used the data to actually make changes at the point of care. This is an example from Vancouver Health. There's also one from Fraser Health Authority and one with our First Nations population in Northern Health. So where are we going from here? Our vision is that we're going to focus on the continuum of care, no longer on sector focus. And why is that? Because look at our stats. Our numbers are showing that continuity and transition scores are flat. They're flat in the emergency department. This is a horrifying graph to me because we introduced rehab in 2011, and I'm a rehab clinician. We had the lowest scores in continuity and transition in the rehab subsector. So here's where we're going. We're integrating PREMs and CROMs. We will never again in the province of British Columbia ask people about their satisfaction and their experience without asking about their outcomes. We will field the Canadian tools for acute inpatient care and an ED tool out of the US with a PROM tool. We'll focus on continuity across transitions in care, and we're working towards blended surveys. We've built on the work of Jeannie Haggerty out of McGill University. Hers are the green definitions. Ours are everything else on the slide. Continuity across transitions and care in British Columbia includes meaningful relationships, supportive of sharing information, and is managed over time, place, and providers. And with patients at the table, the decision was the majority of the questions they said originally should be relationship-based, and over time they changed it to information-based. So my concluding thoughts. If I had the opportunity to develop a provincially coordinated strategy and start over again, these are the lessons that I think would be important. First of all, measuring patient experience is absolutely not an amateur sport. It's hard work. Measuring patient experience is a science, but it's also an art. The stories of patients have to be infused with the data. Patients are integral in survey design. They help us to define what's important, and they ensure that the questions measure what we want to be measuring. Patient experience reports should be available as readily and as frequently as other management reports. Why are leaders expected to look at their overtime reports, their budget reports, but not hear the voice of their patients on a monthly or regular basis? Like accountability, I've already said this, for patient safety, accountability for positive patient experience should rest with everyone, but we still have vice presidents of patient safety. Why don't we have vice presidents of patient experience in every organization? Without accountability frameworks, there's no imperative to act on the results, as good as we want our hearts to be and to do the right thing. And then this is my biggest message to you. We can listen to individual patients' stories, but improving the performance or the experience of one patient in one location will not improve our healthcare system as a whole. Having information that's collected in a representative manner that allows us to blend qualitative and quantitative allows us to really look at where our system's working and where it's not, and to build a system that's stronger and more reflective of what's important to our patients and their families. Thank you. And I'm sorry the presentation was whirlwind, but there's my contact information, and I'd be delighted to talk to anyone about my most favorite topic anytime.
Thank you very much, Lena, for sharing so generously with all the good work that's happening in British Columbia. Good afternoon. My name is Kim Baker. I'm just delighted to be here, and I'm really pleased to see how many people are here at this session this afternoon, because patient experience, it means that it's important to you as well. Certainly what Lena has shared, what some of the examples Paul gave us, and the slide or the video that Anna put up, that shows us not only how important the work that we're trying to do, improve patient measurement and build a strategy for Ontario, but it also tells us there's a lot of work that needs to be done. So I'm going to share with you, I feel very privileged, and I'm going to go back now that I know how this works. Okay, I feel very privileged to be part of this work and starting to build a strategy for Ontario as we think about what it needs to look like to measure patient experience. So I'm going to share some more information about the committee. I'm going to share with you a little bit about the strategy development process, where we are to date, the working definitions that we've used, the principles that we have developed, and how we compare to other jurisdictions in Ontario, and some proposed strategy components in terms of where we are right now. And that's where we're going to get into the interactive part and get some feedback from you. We need your help and thoughts. Most of you in this room have had some experience, either as a patient or a family member in one way or another, and we're looking for some input as we go forward. So our committee is made up of a phenomenal group of people. And as you would expect, very important at the top, we do have patients and family members and people with lived experience who are very generously sharing their perspectives, their experiences, and their perceptions of the system. And it's always eye-opening at all of our meetings when we get this feedback from those folks that can share that with us. We also have individuals with expertise. You can see in the middle area some kind of sector representation. People aren't there necessarily representing sectors. We have sought out people with expertise and experience and interest. And there's a wealth of good work that's happening in Ontario, so lots of folks and resources for us to tap into. And of course, some organizations down at the bottom who are leaders as well and doing a lot of good work. So this is really about also educating ourselves and bringing that good work to our conversations as we figure out a way to propose to move forward. Oops, sorry, twice. So goals and vision. So the goal of the committee, the overall aim, absolutely, to stimulate more superior patient experience measurement. And this is across all sectors and for all patients in Ontario. And ultimately, we want this to translate into stimulating a superior patient experience for all Ontarians. So we think that that would resonate with most people, why the work is so important. At a high level, the strategy development process for the committee started early days with establishing a timeline and some goals and principles, doing some environmental scans to collect some of the information and good work that is out there both internationally and in Ontario and BC, developing strategy components, and then of course more external engagement on the strategy components. And that's where we need to get to start to think about prioritizing those strategy components, eventually drafting a strategy with recommendations in and around March of 2016. So as I mentioned, we're looking to get some feedback from you today on some of those strategy components that we've chunked out. So lots of robust conversation at the committee level around these working definitions. So here today are the working definitions that we're using. Patient, very, very broadly defined, an individual engaging in the healthcare system. The patient includes caregivers, family members, substitute decision makers, and health consumers, so very broadly defined. Patient experience, I'm going to read this because it's a little chunky, but we've been very selective in the words. So the patient's assessment of their care continuum, starting from the time they first connect to the healthcare system. That assessment is influenced by the processes and physical settings of their care and the relationships that develop with their care providers, as well as being shaped by their own expectations of the healthcare system. So these definitions have also been informed by a number of key references that exist, and this is our working definition that we're moving forward with, but we've had lots of robust conversation about that. Principles. Very important for the committee to have some working principles to guide us. So, every patient, caregiver, family member, person who had an interaction with the healthcare system should have an opportunity to voice their feedback. Patient experience measurement within and across healthcare sectors, across the patient journey, across transitions, and for complex conditions and integrated care. Patient experience measurement efforts, we have a focus on measurable and actionable data. Lena talked about the importance of collecting data that can actually be actionable. And organizations encouraged to engage the balanced input from patients, caregivers, and staff in their measurement initiatives, using effective, validated measurement tools, and having a mix of qualitative and quantitative data. I think, Lena, you really hit that home. We've got to make sure that we've got the qualitative information, we've got the patient stories, we've got the face of the patients and the families with us as we're looking at the data. And also considering access and accessibility and equity, very important. The timeliness of the information is important. Sustainability, can we sustain it? Comparability and efficiency in choosing instruments and implementing measurement efforts. So we also, as a guiding principle, need to consider technology as an enabler. And we know we need to continually review and evolve and adapt the patient measurement tools and the processes that we use so that they do resonate and to ensure clarity and transparency and continued relevance moving forward. So those are our key principles. So how do we, Ontario, how do we measure up across other jurisdictions? If you go left to right on the far right of the slide, you can see Ontario. So overall, there's a lack of comparable data, which means we have a limited ability to identify gaps, but more importantly, we've really lost opportunity to compare and learn from some of the other top performers that exist. So there was an environmental scan that was undertaken that looked at a number of jurisdictions, 17 to measure patient measurement, nationally and internationally, but there were a number of commonalities that we believe would apply to Ontario. So there are 5, and I'm going to go through them for you. So the importance of coordinated, the notion that patient experience measurement is coordinated at the system level and tools are selected at the system level. However, they are designed and adopted by providers and patients, and that's the key part that's so important. Sector, condition, and transitions, they don't just measure within sectors, but within conditions and across the transitions of care. A third commonality that's key is it's publicly reported information. So putting the information out there so that these systems and other jurisdictions do publicly report their data. And also another commonality that the data is triangulated. So data is reported alongside outcome, process, and financial indicators. So some, like the NHS, report them alongside the PROMs that we heard about earlier, as another example of that. The importance of centralized. So centralized systems are supported with central supports to standardize the way instruments are designed with providers and patients, and that they develop the methodology. Standardized sampling frames to ensure the most appropriate capture and no duplication were all important as we think about survey fatigue and things like that. So the good news is there's lots of good work out there. We don't have to reinvent all of this. And these commonalities will, from other systems, will support what we all know. And to take a couple quotes that have been passed to me just that really hit it home, we can't manage what we can't measure, and without a standard, there's no logical basis for decision-making or taking action. So Ontario patient experience measurement activities. So in one of the 2 environmental scans conducted, one focused on the quantitative measurement activities within Ontario. And while there are pockets of qualitative measurement in Ontario, like some focus groups that are still underway, they're still developing and not included in this scan that we have here. The heat map here is organized by the level of data that the surveys provide. So provider level surveys also yield system or provincial level data. And the items in black are what is in place now or will be in the near future. And the items in green on the slide are the surveys whose data is publicly reported. So in summary, in Ontario, standardized measurement examples would include home care, cancer care, primary care access, the Commonwealth Fund Health Policy Survey. Semi-standardized would include hospital care, mental health, and palliative care. And non-standardized would be long-term care, primary care, transitions, and other chronic or complex conditions. So there are a few more surveys that are not listed on this slide here. For example, Cancer Care Ontario's Your Learning Matters and Mobile Coach Screening Assessment Visit, and the Registered Nurse Flexible Sigmoidoscopy Patient Experience Survey, which are more specific and under development. So after reviewing best practices in other systems, and in seeing what Ontario is doing, there really are some learnings that are applicable to us. And as I move to the next slide, as we're moving into here we are, as I move to the next, sorry, I was already on the next slide. So these are the proposed strategy components. They're broken up into long-term and short-term. And I want you to have a minute to take a look at them, because this is what I'm going to want to get some of your feedback on. So short-term recommendations, that best practices for instrument review, selection, and implementation, centralized data sharing hub, standing patient experience measurement committee, an inventory of patient measurement instruments, and a platform to share information on new technologies or methods and development of a reporting strategy. Longer-term components on the slide, a system-level benchmarking or target setting process, electronic platform to share best practices for quality improvement, and standards for patient experience similar to NICE or NHS. So these are based on the committee's initial discussions and some survey engagement work that was completed. And this is what we're going to want to get your feedback on. So I'm going to move to the polling question. And just to make sure that you've got your clickers handy, I'm going to put the question up. Okay, everyone has a clicker. I want you to, oh boy, hold on a minute, that's polling number 2. Oh, no, it's number 1. Okay. So here's the first question. When I say, please start keying in now, that's going to start a countdown, a 10-second countdown. So right now I'm giving you time to take a look at the slide, and you're attending HQT here today in your capacity as a. Please key in your response now to start the clock. That was quick. So you can see who we have here today. Let's see. Lots of facility level manager administrators, number 8, followed closely, 7 and 9, system level planners, and lots of others. Okay, thank you for that. So it looks like we've got, let's see, our clickers are working. I don't have a full number. And we're going to move on to the second question. So of the following strategy components, which is the most urgent that Ontario should focus on first? So I'm giving you a moment to take a look. Developing best practice guidelines for survey selection and implementation. Develop centralized data sharing hub to share data across the sectors. Having a standing patient experience measurement committee. Develop an online public inventory of instruments and questions used for patient experience measurement in Ontario. Develop a platform to share new technologies or methods to measure patient experience, or develop a reporting strategy for patient experience indicators. Please start keying in your responses now. Okay. Most urgent, develop a reporting strategy for patient experience indicators, followed by number 1, developing best practice guidelines for survey selection and implementation, closely by number 4, develop an online public inventory of instruments and questions used for patient experience measurement. Okay. I've got 3 more questions. They're not going to be clicker questions, but they're going to be more of an opportunity to hear from you. Thank you for that. So the first question, this is where we want to hear from you, and feel free to come up to the mic and line up. Are there any other components that should be included in the strategy as you reviewed what was on the list? Was there something you were looking for, you were surprised it wasn't there, you've been thinking about it as you've been hearing the presentations today? Okay. Can we put the list back up? Yep. Let's see if we can do that. I'm trying my back button. I don't think my back buttons were, oh, there, well, hold on, just a minute. There we are. I did see some other hands. Did some folks have some? Oh, there, great.
I think.
I don't know, no, are the mics on?
I think it's on, just have to
There.
get it from the board. 2, 1, 2, yes.
Yep, I can
it's
hear you.
working. My comment actually relates to the whole topic as a person who has, as a child with complex continuing needs. So I've been receiving care, and I also had the opportunity to work at one of the major teaching hospitals in Ontario, and I had the privilege of looking at the information that for the patient satisfaction at the time, patient experience. One thing that I would strongly recommend the committee to consider is to include the family in the whole spectrum of the measurement as well, because having been a parent, at the times I could understand when people came to our hospital telling me or telling us as an institution some of the things that we couldn't, as an administrators, we couldn't understand till I experienced it myself. So I think it's critical to include the family and caregivers or whoever is involved in the care of the individuals as part of the strategy as well. It's critical piece. The other piece that I just want to quickly comment is the fact that a ton of work had been already done by the former OHQC on this front. I had the opportunity to work at the OHQC way back in 2010 when it was actually started. We developed a crosswalk of all the indicators that were reported in British Columbia, Saskatchewan, Alberta, and we had a pan-Canadian group to look at all this information. So I encourage the committee to dig out all that information and use some of that, but I think it will be very, very useful for this exercise. So the 2 comments that I had. Thank you.
Thank you very much for that. And we are taking notes as people bring those comments and suggestions forward. That's very helpful. Thank you. I see some other people maybe possibly making their way to the mic.
Thank you. Can you hear me okay?
Maybe lean a little closer.
Can you hear me now?
Yeah.
Okay. So many of these, by the nature of it, need to be a little bit more generalized so you can apply it. But one of the questions I had, because this is all over, I'm all over this currently, in my other hat I wear as a student in quality. And one of it has to do with how to take the qualitative information that is so rich and fulsome, particularly if you're going to engage the elderly in their experience, and then develop a way of making it quantitative so it's actionable. We talk about the stories, which are so important. I'm in the process of trying to develop a way of making it some kind of a validated instrument when I have my interviews with them. But there needs to be a way that we can apply that. And so I'm not sure if that's part of number 5, but if it is part of number 5, it needs to be very specific so we can use it. Thank you.
Okay, thank you. Are there any other hands? If people are maybe far away from the mic, feel free to give a hand too.
So I think it's important that we get started on this, but having said that, we've been getting feedback for, I think, a number of years on what patients' experience is, and I don't know that we've really done much about it. So I'm concerned that we're collecting this information, we're engaging patients, but what are we going to do? Like, and we need to have some way of showing people that as their concerns are coming forward, we have a strategy to manage it. You know, some of the questions that Mr. Taylor brought up, I've heard many, many times, and I don't have the answers, and I work in healthcare, so.
Yeah, thank you.
Thank you for that wonderful presentation, Kim and Lena. One insight that I wanted to add as this strategy is being developed is I think it's important that a lot of the organizations that are already doing some of this work collaborate. For example, CAIHI and the Your Health Systems website, if they have any indicators around patient experience, but also to learn from the experience in British Columbia, because the jurisdiction there, it seems that it was mandatory to measure patient experience and patient-reported outcomes. So maybe we can, as we develop our strategy, look at some of the indicators that they're using, how valid they are, and how reliable they are for some cross-jurisdictional learning.
Great, thank you.
I'd like to suggest a missing component is accountability, in particular to put accountability on CEOs, boards, and senior management teams. Until and unless there's accountability, there's a lot of goodwill going on here, but nothing really is going to happen.
Yeah, thanks for that. I think we heard that in Lena's presentation, some thinking about it, but I think you've broadened that, Ted. Thanks. Elise?
Okay, so I have a question really for Lena. When you look at this list, is there anything that we were missing on it, and is there anything you would emphasize?
This is on. I guess, you know, if I was asked to participate in this clicker exercise, I would have chosen number 3 as the first and most important strategy, because I think that bringing together the right people with the right vision and beginning to work forward would in fact address all of these. That's my view. In terms of what's missing, I would echo, is it Ted? Ted's comment around the accountability framework, which I think I indicated clearly was my bias. I think the other thing is that maybe the engagement strategy for how to include patients in helping to design or co-design the strategy and to continue to monitor and in their own way hold the province and the players accountable for how the data is used as well. I might add that.
Thank you.
That's great. I think I have 2 more folks here, then I'm going to move to the next question. Go ahead.
Thank you and to everybody for this wonderful presentation. And I would suggest one component in measurement of the patient experience is patient engagement. I think is one of the key we need to consider, and also to improve health equity. I think the diversity, culture, and diversity should be a component to include in the patient experience that can be helpful for health equity.
That's a great comment. Thank you. Particular to the populations wherein the data and information is being gathered.
Sorry, I come from the vendor side. The one thing I would say is that actually the vendors, the service providers and the technologies that you're going to be utilizing and understanding what they actually can provide as partners in this. Because one thing that is talked about is all the things that we want to do, but then the second thing is when we take it home to the organization, we all still have one vendor that we go to for collecting patients' report satisfaction data, and what can we actually do beyond that, and are there other sort of things around that? So I would very much try to bring in the other partners in this.
Thank you. That's a very pragmatic comment. Okay, last point on this question. I'm going to move to 2 more.
Yeah. I would like to add, the tools and instruments which is required for monitoring the actions taken after these surveys have been, the data have been analyzed, whether it was actually implemented, how do we monitor them? That should be part of the strategy in terms of what actions were taken out of those feedbacks that we received from patients.
The follow through. Thank you. Next question. I'm going to go, oh, there. What elements would you like to see in a patient experience measurement reporting strategy? Talked about the importance of reporting this information. We just had some feedback on that. Are there any more specifics when you think about a reporting strategy?
Just wanted to mention this idea of public reporting. Also, there's some evidence to show within the literature that public reporting of hospital indicators such as morbidity and mortality reduces morbidity and mortality in hospitals. Lena, you might be more familiar with this than I do. I'm not sure if reporting PROMs publicly improves patient outcomes in certain hospitals, but I do believe that the availability of those results on a publicly available tool or website would be useful. And I'd be really interested in hearing your thoughts on this, Kim and Lena.
So Lena or Kim? Well, I think, Lena, you've probably got some more experience in BC with that information, so I'm going to ask Lena to respond to that.
Well, I'm not sure that we have a complete picture in BC. I think there's probably a better experience through the US and the UK. But what I would say is that there's always a caveat, right? And we know that when we start reporting publicly information such as patient experience, patient-reported outcomes, that there's a danger. There's a danger that the way the information is reported is that it's presented to, and I'll use the word protect, certain stakeholders. So the whole debate, and I know CIHI is exploring that right now, do we report percent positive, where in fact, everything looks like people are, 89 to 97% satisfied, or do we report top box, the number of people who said excellent or gave it a perfect 10 or a 9 and 10 combined, right? So I think that's one of the issues. And I think the other one is that we have seen evidence in the US that the numbers can be gamed. So if a patient goes to the physician expecting to receive an antibiotic, they're hacking, they're sick, doctor, I'm sick, I need antibiotics. The doctor understands, the importance of antimicrobial stewardship, but at the same time recognizes that the patient is going to potentially receive a survey. So, there's been some publication on that challenge as well. So my response to your question would be, I personally believe that reporting this information is important, and it can be used to stimulate action because consumers and the public then become monitors of how well we're doing, but it has to be done very carefully. And it has to be done with consideration of all the stakeholders, and again with the guiding principle of what is the right thing to do and what education do we have to provide for everyone so that it's not an unrepresented rate my hospital, such as Paul described.
Our time is up. I think that's an excellent note for us to end on. We received some great feedback and comments from the audience today, so thank you for that. And I also think this outlines why this is not an amateur sport. And I also want to acknowledge the presentations, Lena, Paul, Anna. Thank you very much for being here and fielding some of the questions from the audience. And we're not going to get to our third question, but you can provide more feedback here on the strategy, which is very welcome, and here's the link, and these materials will be available for you. Thank you so much for coming to this session today. Enjoy the rest of the conference.